My name is Brian Hyett, and I'm with Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. And today I'm presenting our work, a novel upper gastrointestinal bleeding risk score, AIM-65, is more accurate than the modified Blatchford score at predicting mortality and rebleeding. The reason we undertook this study is because upper gastrointestinal bleeding is quite common, an estimated 3 to 15% in the literature of mortality associated with it. And last year, guidelines came out which recommended early risk stratification by using prognostic scales. However, most of us know that in clinical practice, such scales are not currently employed commonly when patients come in through the emergency room. So previously, with a state of Pennsylvania database of greater than 60,000 patients, we derived a risk score we called AIM-65. The score included the following factors: an albumin of less than 3.0, an INR greater than 1.5, altered mental status, a systolic pressure of less than 90, and age greater than 65 years, hence AIM-65. Mortality risk was characterized as low risk, which is an AIM-65 less than 2 risk factors, or high risk, which is an AIM-65 greater than 2 risk factors. So for our current study, the goal was to evaluate the AIM-65 risk stratification score in a separate patient population from that which it was derived, and compare with the modified Blatchford risk score. The secondary aim was to assess rebleeding rates and compare low and high risk patients for both scores. Our hospital's research patient database was queried for ICD-9 codes related to upper gastrointestinal bleeding. The diagnosis was confirmed by review of discharge summaries by 2 separate reviewers. And over a 5-year period, 278 patients were identified who met the inclusion criteria and had adequate documentation to calculate the AIM-65 or modified Blatchford risk score scales. And then the outcomes measured were in-hospital mortality and rebleeding. And finally, an area under the receiver operating characteristic curve was subsequently calculated to compare the scores. So, results showed that our score, the AIM-65, was superior to the modified Blatchford in predicting death, with an AUROC of 0.93 versus 0.71 for the modified Blatchford risk score. Of the 198 patients with low AIM scores, those are less than 2, 1 patient died. Among the 80 patients with high AIM-65 scores, or greater than equal to 2, 17 or 21% of the patients died. The percentage of in-hospital rebleeding was 3% for the low-risk group versus 10% for the high-risk group. And for the modified Blatchford risk score, the percentage of in-hospital rebleeding was not significantly different between the two groups. So we concluded that our score, the AIM-65, was highly predictive of mortality in upper gastrointestinal bleeding and more accurate than the modified Blatchford risk score. Our score predicts in-hospital rebleeding with higher accuracy than the Blatchford risk score. In the future, we're planning prospective studies, and we're very intrigued by the use of such a score because of its ease of calculation and because of the fact that it's a very easy to memorize score. We're hoping that patients will be able to be triaged early in their ER admissions to either ICU or floor care, depending on their scores, and that the timing of endoscopy can be determined as well based on score. But of course, future study will determine this.